in Duhok. This is the center which we have built the last 3-4 years for prevention and treatment of child mental health. And when this war started, we gathered our professionals, and made our teams and visited the camps scattered around the city of Duhok. You know, about 2 months after the start of the war, the population in the city of Duhok increased, doubled actually, because of the huge number of IDPs, internally displaced people, who gathered in the city of Duhok and around the city of Duhok. And we could find the children, when we had our teams consisting of at least 1 child psychiatrist, at least 1 clinical psychologist, and 1 social worker, and even other professionals, allied professionals, who wanted to be connected with us, such as teachers or nurses. We found the collections of children like that. Children were left without care, actually, and it was not, of course, intentionally, but the adults were occupied with the issues of the war. Majority of the people of Shingal were captured in the hands of ISIS, and especially women and children, they were considered as slaves, and the men were killed directly. Those who escaped were in this tents, collections of tents around the city of Duhok, or inside the city of Duhok, in the families. They took them at the beginning. And there were a lot of children. You know, this society is a very conservative society, and the families are extended families. More than 3 generations are living in the same family, and the older person is deciding. And the adults follow the instructions from the heading, and more than 7 children per family, per parents, of course, are there. So there's a huge families, and children are a lot, and they are just moving around between the tents without anything to do. No schools, no play, no adults to listen to their histories and to take care or pay attention to them. So they gathered just around any person coming and asking them questions. It was an issue for us how to collect these children in groups, actually. This made us to think of some kind of intervention which must be short, must be group therapy, and must have many professions to be included. And we developed the CIPCA based on recent knowledge from these fields of science. First aid, that's both psychological first aid and the somatic first aid. Prevention, generally speaking, we know that prevention is better than treatment. And vaccination. Why we don't have vaccination in psychiatry? We have the vaccination in other medical branches. And psychological trauma may be one of the ways, the best prepared to develop such a method of prevention. Psychopathology is increasing in the significance in the new recent research and clinical work, and prenatal diagnosis is becoming more important nowadays because of the technical development. Early childhood investigations and interventions are becoming more and more of interest, even to prevent adult psychopathology. We depended on the multidisciplinary child and adolescent psychiatry character and brought our techniques from the cognitive behavioral therapy, which are most possible to suitable in our society according to our experiences, and we depended mostly on salatogenesis instead of pathogenesis, as you understand. That's seeking after the origin of health instead of looking for the pathology. Recent trauma theories are also our origin for our procedures. CIPCA is a time-saving and cost-effective crisis intervention. It's early identification of symptoms, symptomatology among children, and at the same time we provide treatment for those who already show symptoms or kind of disorders. It is an evidence-based methodology that is research-friendly. Everything must be measured. Preventing post-traumatic psychopathology is our principles, as I said, and development of healthy personality is our last aim. Those children must receive adequate help in order to develop healthy personality in the future. The CIPCA is consisting of 1 week training for trainers in group. That's a method which is known in the third world. NGOs are using it, training of trainers. 2 facilitators train up to 30 trainers. Every 2 trainers train up to 30 group leaders. And every 2 group leaders lead 30 children in a single 1-hour group intervention. The target is children and adolescents in crisis situation. And it doesn't mean that it must be a war or a catastrophe or disaster. You can use this method even for other types of crisis. It is depending on task-shifting principles. That means that it is not only the doctor who is active. Every profession in the team are active and doing something to complete the others. Early crisis intervention and screening. We do the same thing during the same group intervention. One of the group leaders is leading the discussion and intervention, a conversation among the children, and the second one is observing and recording the symptoms in order to refer them to adequate child psychiatric individual assessment for eventual treatment. The group dynamic support is our principle. That means that the children who started to describe or tell its narrative or story of trauma, then the others are commenting, and many of them shared the same events, of course. So it was supportive for the children themselves to support each other in order to come and express their thoughts, their feelings about the traumatic events. And the leaders' responsibility was, have been learned to how to try to help the children to express the thoughts clearly and emotions without being afraid or stopped by anything, and everything is spontaneous, and then to try to help the children to find out alternative positive thoughts and emotions. Individual assessment and treatment is done when a child is showing any symptom and referred to a child psychiatrist individual assessment, that there will be 1 hour's assessment of that child's problem in order to see if child has developed any diagnosis, do the children need help or treatment or not. This is just to show some pictures. This is WHO's office in Duhok, the city of Duhok, who visited us at the Metin Health House, and we prepared for our training of trainers and conducting the intervention. This is how the participants, the professionals who were learned to become certified trainers, and this is how 2 of the trainers, you see the yellow clothes, they are the certified trainers, and they trained all these teachers. These are the teachers of the IDPs themselves who have participated in the training to become certified group leaders. And you can see this is one of the sessions, how the group leaders are sitting and gathering the children in order to help them to express their emotions, to have the use of the CIPCA. We use for assessment 4 instruments: Child Behavior Checklist, CBCL. I hope many of you are familiar with that, otherwise you can ask me then. Crisis Intervention Guidelines, it is the core instrument in our intervention which leads to the group leader to allow children to express emotions and thoughts, and to take, instead of the negative thoughts and emotions, positive alternatives. Crisis screening instrument is to collect about 12 symptoms of psychological distress. If any of them is apparent on a child during the group intervention, then the child is to be referred to a child psychiatric assessment. Modified family map, this is genogram. This is used by the child psychiatrist during the individual assessment, and the main purpose is to identify protective factors and risk factors in the family and in the child. Well, our pilot project, we had 2,200 children who were referred, among that 22,000 IDP children who received CIPCA, and that is about 5% of them showed the symptoms, and among the referred to the assessment, about 50% of them showed diagnosis needing treatment. At the first year follow-up, we had only 28 children, actually, because of the lack of the funds. You know, it is very difficult to motivate to have a follow-up for a project. But we could find 28 children. You see the green line is those children who didn't receive CIPCA, and they show deterioration in all symptoms according to CBCL. Compared with the blue one, that is those children who received CIPCA, and there is here clear diminished symptomatology. Boys and girls showed no differences, actually, no significance as such. And during the 2 years follow-up, we could find further improvement among children who had received CIPCA, while those who didn't receive CIPCA improved also a little bit, not such as those who received CIPCA, of course, but probably due to the natural healing process, they started to improve also. Comparing the two tests, index and 1 year and 2 year follow-up, you can see clearly that the improvement among CIPCA children is continuous during all the time, while those who didn't receive CIPCA, you see a deterioration at the beginning, and then they started to become better. That is what I wanted to let you know, and due to a short of time, I'm going to leave you to think about that, and if you have any questions, you are welcome to contact me. Thank you very much.